Thank you. So I'll be talking about the whole concept of periocular aesthetics from the perspective of a comprehensive ophthalmologist, and who has his or her own standalone setup with multiple specialists visiting or things of that sort. So when we talk about aesthetic procedures that typically an oculoplastic surgeon or a comprehensive ophthalmology looks at, it includes ptosis. Patients oftentimes come to us with complaints of under eye hollows or under eye dark circles, and we often tell them, oh, this is just lack of sleep, or you've been sitting in the AC for too long, and just send them off. When we now have very, very targeted techniques of correcting them. Also, we'll be looking at how botulinum toxin can help in improving the aesthetic appearance of patients, especially in the area around the eye, under eye bags or upper lid hooding, and how we can actually promote aesthetic procedures and aesthetic consults in our clinic. So most of us focus on the patient's complaints, but a significant proportion of oculoplastic procedures arise from the doctor's observations. So a patient may come with, say, blurred vision or not being able to read distant things clearly, and you may notice a mild ptosis. Now it's important that we need to tell them, have you noticed that this eye is actually smaller? Have a look at it, look at photos that you've gotten clicked, and you'll probably look, and then they go back, and then they'll come back to you in some time and say, yeah, I think I've noticed my eye is a little small, what can be done for you? So it's important that we also actively counsel them, and we can speak to our oculoplasty colleagues and ask for them to share some before and after photos of, say, a blepharoplasty or a ptosis surgery, that we can actually show to the patient, because before and after pics are a real game changer. When they see a patient who's had a similar procedure done for a condition that they have and has improved, that really makes a difference, because undergoing a surgery can be a very a large rate limiting step. So ptosis often missed, especially when we have patients who wear -6, -7, high minus glasses, come in for LASIK. So from LVP, they actually published a study where every patient undergoing LASIK were asked to remove their glasses, and they had the photography department click photos in all gazes. 6% of these patients had mild or moderate severe, of which half of them opted to undergo ptosis surgery after the LASIK surgery. So by the simple procedure of having them click a photograph, so they know how they look like after the refractive surgery, and for them to pick up some minor asymmetries or ptosis is very important. Even after cataract surgery, you oftentimes see, and then we reassure them and send them back, but we actually need to actively counsel them to get them to operate these cases. Now, the other thing that we oftentimes get is under eye dark circles or under eye hollows or pigmentation, and we ask what can be done. So there are different reasons why this happens. There is certainly some periocular pigmentation which is hereditary and can be caused by certain drugs as well. And there's something known as tear trough hollow. Now, tear trough hollow is this deformity that we see, or this area of hollowness that extends from the area inferolaterally from the medial canthus to approximately the mid-pupillary line, and becomes progressively more prominent with aging. And that is actually a cutaneous groove along the bone, the anterior lacrimal crest. And how do we treat that? We use a filler injection. Now, this is exactly hyaluronic acid, the same kind that is used in viscoelastics, but of course it's a higher molecular weight which is cross-linked. And these are different fillers that are available for use in different parts of the face. So what do we do in these cases is that we anesthetize the area with topical Prilox gel, and on the pre-periosteal plane is where we inject small aliquot. So it's much like how you have two tiles in the bathroom, and there is a small groove between the two tiles, and you put in a little bit of cement to flatten out the whole thing. That's exactly what is being done. This is called a tear trough filler. It's a simple procedure that can be done in the OPD. As you can see, as long as you're away from major neurovascular bundles, it has a very good effect, and this is immediately post-procedure. You can see the difference. So patients who actually come to you with under eye hollows or under eye pigmentation, they have a solution, whether it is something as subtle, very subtle, or a little moderate, or something very severe like this. Now here we are able to treat the hollowing with the filler injections, but the pigmentation persists. Now for this pigmentation, you can actually send the patient to a dermatologist who can do carbon dioxide lasers. Every dermatologist has a carbon dioxide laser. It is their phaco machine. It is their bread and butter. So don't be afraid to refer to a dermatologist. Over time, they will begin referring patients back to you. Even men, it's not that these procedures are only for women. This is a gentleman who's getting married, said, my eyes look, I look always like as a patient. People ask me, have I drunk in the morning? And all they had was a under eye hollows, which needs to be filled with filler, and it again improves very well. So this is the patient who underwent filler and 1 session of carbon dioxide laser, and you can see that the hollowing is improved, but pigmentation takes a little time to go. Again, pigmentation is hollowing is improved and pigmentation is also improved. So fillers are used in all over the face, but I think in terms of starting off practice, under eye area is a very good place to offer. Next, I'll talk a little bit of Botox. Botox is an injectable medication. We use it in squint, in oculoplastics, in a lot of other specialties, neurology, urology. It is a reversible medication which acts locally by paralyzing the muscles. How does paralyzing muscle help? So there are creases and folds that we have on our face. Now, this is a patient who's looking normal on the left. Now, you ask her to raise her eyebrows, she lifts her eyebrows, the frontalis contracts, and you get these creases or muscle lines. This is a static crease, a dynamic crease, sorry. The moment the muscle is in movement, it creates a dynamic crease. Over time, repeated use of the same muscle, the muscle contracting, the furrows being created, a dynamic crease will go up and becoming a static crease. So by injecting muscle in Botox into the muscle in the frontalis, we prevent the dynamic crease from appearing, but don't inhibit the action of the muscle. So the muscle will contract, but the folds or the creases will not be seen. As compared to this, now this is a patient who's having no expression on her face, but still she's got all the creases, and these are static creases. Once a static crease has developed, you can inject a liter of Botox, nothing is going to happen. So you can delay these signs of aging from occurring by periodically getting Botox done to prevent the dynamic creases from becoming a static crease. So it usually takes 3 to 4 days to kick in. The peak effect is seen between 2 to 3 weeks, and it lasts for about 4 months. Botulinum toxin does not last for 4 months. Patients may come and tell you, we have certain spasm patients that, oh, last time the injection you gave me worked for 6-8 months. Well, that works on their mind and not actually on their eyeballs. So where do we inject? We can inject on the glabellar line, the frown lines, crow's feet. I'll show you. So this is in the case of frown lines. So what we are doing is asking the patient to frown, and you can see when she's frowning, these wrinkles appear. These are called the Levin lines because they are like 1 and 1 Levin. This muscle is the corrugator muscle. That is the one which is contracting and creating that line. So we inject in that. This is the procerus muscle that brings the eyebrow down. So that's where we injecting. So by injecting in the procerus, the corrugators, we are taking away the Levin lines, the frown lines, and then we inject onto the frontalis muscle. And when we inject onto the frontalis muscle, we keep a gap of 1 centimeter above the eyebrow, which is a no injection zone. At least 1 centimeter is the space, and then we inject at multiple spots. The effect of this is a patient frowning. You can see the Levin lines. The same patient frowning, but the Levin lines or the eyebrow frown lines are not seen. Here, when she's raising her eyebrow, the frowns are, the furrows are visible. Again, here she's raising the eyebrow after the injection, the furrows have gone away. Similarly, for crow's feet, when people smile, sometimes they get very, very prominent creases at the lateral canthus. Those are called crow's feet, because if you see crow's feet, they are like 4 or 5 lines going from a single point. So it's like the paw of a crow. Again, injecting 4 or 5 units of Botox in that corner works very well. So especially when they smile, these lines that are seen at this corner, they all go away. And again, this is before and after. Again, before and after. Crow's feet work very well. They work for 3 months and 3 to 4 months. And these are all OPD procedures. You don't need to go to the OT for this. Here, by injecting just under the eyebrow in this orbicularis, we are able to create an eyebrow lift so that patients can have a gentle temporal lift in the eyebrow. We can also do, in a lot of patients, when they smile, their eyes become little small because there's a small bump or muscle that of tissue that accumulates there. That's because when we smile, this orbicularis it gets pushed up because the zygomaticus and all our facial muscles move upward when we smile. Orbicularis contracts, and there's this small belly of orbicularis that occurs, is seen under the eyelid. Injecting small 5 units of Botox over there, exactly in this, the pretarsal orbicularis, works very well. So these patients go from having this jelly roll under the eye to not having that, and that completely changes the appearance of the face. A lot of patients get conscious when they smile, they say their eyes become small. Finally, I'll come to under eye bags. Now, when patients like this come to us and tell us that I can't see well, like Arjuna who saw the eye of the fish in the well, we can only see the NS2, NS3 in that eye, and we miss the under eye sagging, the upper eyelid hooding. So these are patients who have fat prolapse. I'll just take 1 minute more. So this occurs even in younger patients, and the way to confirm that it is fat and nothing else is you ask the patient to look up. When the patient looks up, the orbital septum relaxes and the fat bulges forward, so it worsens on up gaze. And when they look down, the septum tightens, the inferior rectus pulls it back, the fat improves appearance on down gaze. The same thing is seen even in older patients, but in older patients you will see they will have some inferior scleral show and excess skin, so they may need skin tightening procedure as well. So these are cases that you can always offer to refer to your oculoplastic colleague. Patients who undergone transconjunctival blepharoplasty, it's done from the inner aspect of the eyelid through the root just under the tarsal border. We excise fat, we transpose fat under the periosteum. All oculoplastic surgeons are very familiar with this route. So when you have patients who come for this, don't prescribe refreshed ears and tell them to come after 3 months. Send them to your oculoplastic surgeon or ask them to come over, and it will really help. Again, patients who come saying their eyes look tired with a conjunctival transconjunctival or transcutaneous blepharoplasty, they can work really well. This is my mother-in-law, and she's very happy with the surgery. This is again another patient who had excessive skin hooding. So you can't even see the upper lid margin, and with that you're able to treat that. Some patients may even have lacrimal gland prolapse, so you're able to treat that with a blepharoplasty and a lacrimal gland reposition. Again, patient came for cataract consultation. My colleague was kind enough to look behind the fish eye and say that you should get your eye also looked, and patient was actually motivated enough. Look how many years we've knocked off his face, at least 10-15 years. And he was so happy that he says, now I actually am able to see more because the field of vision has improved. Again, the same thing for this. This is a quad bleph, both upper, both lower. It knocks off at least 10-12 years of their face. Patients who come to us like this, we say, oh, you have cholesterol, look at this cholesterol that has occurred. Well, that cholesterol xanthelasma can be excised. Agreed, there are recurrence rates. There is no mode of treatment with xanthelasma that does not have recurrence rates. Also, incidentally, only 1/3 of patients with cutaneous xanthelasma have hypercholesterolemia, and 1/3 of the patients above the age of 40 also have hypercholesterolemia. Hypercholesterolemia has no correlation with xanthelasma. So save the patient that blood test by not asking them to do a cholesterol level, because most often than not, it's going to be normal. At least they're happy that their concerns are addressed. Small lids, little bumps, warts, papillomas, they may not make a difference. So patient really didn't have a complaint about these things, but if you're able to improve the quality of life by improving their aesthetic outcome, that is something we should offer the patients. I'll finish off. Chemical peels are a little advanced, which most dermatologists do. So to summarize, aesthetic procedures go hand in hand with core ophthalmology. Ocular aesthetics and periocular aesthetics is as much as ophthalmology as multifocal and trifocal lenses. Active counseling and generating consults for your oculoplastic surgeon, offering a patient a free consult with an oculoplastic surgeon, telling them that for the next few months we'll send patients, don't charge them, we'll consult with them. Over time they will convert to surgeries. Show them before and after pics, because that is the main game changer. You can have screens in your waiting room with patients with mild ptosis before and after, blepharoplasty before and after. I call that waiting room passive promotion. Automatically they know that this is also done here, and slowly by word of mouth it will improve. And if you really want to expand your practice and do these procedures yourself, there are multiple courses that offer new skill acquisition for general ophthalmologists. I'll be happy to share details of this offline. Thank you so much for your time and for the invitation. Are there any questions at the end we can take?
Yeah. Thank you, Dr. Akshay. That was a very wonderful.